Good afternoon, everyone. Today we are going to discuss a Viva practice on the pediatric urology table. As you already know, the pediatric urology table is 20 minutes continuous. So we will try to do a recording like that so that it will be useful for you. So we will go through the two most important scenarios in pediatric urology. We have got a trainee who has agreed to record the Viva practice today. Many thanks for that. Shall we start now?
Yes, please.
Brilliant, thank you. So you are in the pediatric urology table. You are on call and you are called by the pediatrics team for a 8-month-old male child who was admitted with fever, frequency of urination and vomiting. How would you want to approach this child?
So I will go to review this child myself, since my concern is that it could be urinary tract infection with the history of fever and vomiting. So I will review the child. I will take a brief history from the parent about any antenatal problem, like hydronephrosis or anything, about his delivery, full-term birth weight, about any previous urinary tract infection, any other urological diagnosis during his previous time, and also I will ask about how the child is feeding, is he thriving, gaining weight, opening his bowel regularly, and difficulty in passing urine. I will also exclude any drug allergy, ask about the use of any medication, any surgery done for the child during this time. And then I will examine him in the presence of chaperone with the parent consent. I will examine his tummy. I will examine first his weight and height compared to the chart. I will check his temperature and vital signs to make sure that he's hemodynamically stable. And then I will examine his loin, looking for any mass or tenderness. I'll examine his bladder, looking for any palpable bladder or tenderness. I will examine the groin and genitalia, and I will examine the back as well.
Okay. What all this child, history says that there is only constipation, and this is the third episode of a culture-proven UTI. So he had 2 previous episodes. So how do you need any investigations now?
Yeah, I will try to get a urine sample, and the clean catch urine sample is the best one. Mm-hmm. So I'll try to send a urine sample for assessment first for urine dipstick, and then for culture and sensitivity. I will do a blood test for full blood count, inflammatory marker, and kidney function. Mm-hmm. And since the child is having a history of a previous infection as well, so I will arrange for an urgent ultrasound as well.
Okay. What are your differential diagnoses in this case?
Since there is a fever, a vomiting, and some pain passing urine, I think this is quite suggestive of UTI. However, sometimes UTI in children is presented with non-specific symptoms, just fever, failure to thrive, and vomiting. Mm-hmm. The other possibility is could be gastroenteritis or other infection.
Okay. What is bowel bladder dysfunction?
Usually, it's sometimes there is an association between difficulty in passing urine and constipation, which they call it dysfunctional elimination syndrome, I think also, due to some pelvic floor spasm which cause difficulty in passing urine, and also constipation, and it may present as a UTI in children and constipation at the same time.
Okay. How do you like this child to be managed?
So for this child, we have the NICE guideline 2007 for assessment and treatment of pediatric UTI. So I will check his urine sample to see, and if we find in the urine sample any positive leukocyte or nitrate, any one of them, then this is regarded as infection in addition to the symptoms. So I will send the sample for cultural sensitivity and start the patient on antibiotic therapy. And since it is associated with fever in this child, so usually the definition of pyelonephritis in children is high fever more than 38 with positive urine sample, or fever less than 38 but associated with positive urine sample and loin pain.
Okay. Will you start the child on IV fluids because of his vomiting?
Yeah, definitely. I'll give the child IV fluid, give him antibiotic for the fever, and start him on IV antibiotic, preferably amoxicillin or cephalosporin.
Okay. According to the NICE guidelines, what is the first line option if there is a low risk of resistance in the trust antibiogram?
Usually for the simple UTI, for the cystitis, we can give trimethoprim or nitrofurantoin. But for the pyelonephritis, I think we usually start with cephalosporin or amoxicillin.
Okay, so this child has no abdominal tenderness or loin tenderness. It's just fever and dysuria and history of constipation and this 2 previous episodes of proven UTI. This is the 3rd episode. So how do you like to prescribe trimethoprim? What is the dose of trimethoprim?
So treatment dose of trimethoprim is 4 milligram per kg in 2 divided doses.
Okay, and how long will you give it for?
It will be given, since there is a fever, I will give it for 7 to 10 days.
Okay, and this child, now it is a 3rd episode of admission. How do you define the recurrent UTI?
So in children, recurrent UTI defined as either 3 cystitis in 1 year, or 2 pyelonephritis, or 1 of each in 1 year.
Okay, and you said that you will follow this child with imaging, isn't it? What all imaging will you do?
So for this child, I will do his age is 8 months now. So for this child, he will have a urinary ultrasound in 6 weeks as a follow-up, and I will arrange also for a DMSA scan in 4 to 6 months. And if he have a suggestive finding like family history of VUR or hydronephrosis in the ultrasound, or non-E. coli infection, then I will arrange for MCUG as well.
Well done. What are the features of atypical UTI as per NICE guidelines?
So the atypical UTI defined is when the child is seriously ill or septic, if the infection is caused by non-E. coli pathogens, or there is no response to antibiotic therapy after 48 hours, and also if there is any difficulty in passing urine or palpable bladder, and if there is a raised serum creatinine. So any of these is regarded as atypical UTI.
Okay, and will you, after this child recovers from the current episode, will you prescribe him antibiotic prophylaxis?
Yes, since it is recurrent urinary tract infection, this is the 3rd episode, so I will keep him on trimethoprim 2 milligram per kg once daily.
Okay, and what is the role of circumcision in male children with recurrent UTI?
So I am aware of a study showing the benefit of circumcision in children who are prone to recurrent infection. And I think for the normal population, you need to do 111 circumcision to prevent 1 infection. In case of recurrent infection, it is 11 circumcision to prevent 1 infection. And in case of other pathologies like posterior valve or reflux, it is 1 in 4, I think.
Okay. How do you follow up this child?
So I will follow up this child by, as I explained, by having ultrasound in 6 weeks, DMSA in 4 to 6 months, and MCG if indicated. I will see him in the clinic in 3 months with a repeat urine sample, check his symptoms again, and I will keep him on the prophylactic antibiotic, usually for 12 months. Without infection or up to the age of potty training. If there is anything suggestive of parenchymal thinning or hypertension, proteinuria, in this case, I would refer the child also for the pediatric nephrology review.
Okay, so that's time now, so we'll stop there.
Thank you.
So we'll go to the next scenario.
Yes, please.
So this time you are sitting in the pediatric urology outpatients, and there is a referral, like a 2-week wait referral for a 3-year-old boy referred for visible hematuria. How do you want to proceed?
Well, this is regarded as urgent 2-week wait referral, so I will see the child with his parents. I will take a brief history about any antenatal problem, and observed about his birth weight was mature of full term or not. I will ask about his any problem during delivery, the use of any assisted devices. I will ask about whether he is passing urine normally without any difficulty, any history of urinary tract infection before, whether he is thriving and gaining weight, any vomiting, constipation or abdominal pain. Also, I will ask about any other medical problem or surgical problem diagnosed during this 3 years. I will ask about the family history, of any history of cancer in the family or stones as well. And I will then examine the child, checking his height, weight, and compare it to the chart, checking his vital signs, and then I will examine him, looking for any palpable lymph node, looking for any palpable mass in the loin or in the abdomen, examine the genitalia, and examine the back as well, and then I will arrange for urine dipstick to check his urine, and blood tests including full blood count, coagulation profile, and kidney function.
Okay. In a child with hematuria, what is the importance of looking for urinary proteins?
Yeah, so urinary protein may indicate some form of nephropathy, which is could be related to chronic infection in the kidney associated with VUR or other congenital anomaly of the kidney, causing the proteinuria and hematuria at the same time.
Okay.
That's what I'm thinking about.
Okay, so this child has visible hematuria, asymptomatic, no previous significant history. On your examination, you felt that there is an abnormal mass you can feel in the right loin. What is the most common cause of macroscopic or visible hematuria in asymptomatic patients?
I think in asymptomatic child, it could be a renal tumor, which is mostly Wilms tumor. Mm-hmm. If there is pain, then I would think about maybe infection or a stone. So I think this child may have a Wilms tumor, so I will arrange for an urgent imaging.
Okay. Not for this child, but generally, for a patient with visible hematuria, all investigations normal. When will you refer to nephrology? What are the indications?
The indication, if the urine sample showing some proteinuria, if there is abnormal kidney function, if there is parenchymal thinning on imaging of the kidney, and if there is high blood pressure.
Okay. For this child with abnormal mass in the right loin, what is your next plan?
So since my suspicion is a possible worms tumor, I will arrange for imaging for diagnosis and staging. In this case, it will be an MRI of the abdomen.
Okay. What are your differential diagnoses in this case?
My differential diagnosis, it could be other abdominal tumor or masses. At this age of 3 years, it could be a neuroblastoma, one of the differential diagnoses, and the other possibility, it could be leukemia or lymphoma, which are the commonest malignancy in children at this age.
Okay. What percentage of Wilms tumor children present with visible hematuria?
I think 90% of them, they present with visible hematuria.
Okay. And what percentage of Wilms tumor present as bilateral?
Only 5% of Wilms tumor is bilateral.
Okay. So if you are doing an MRI scan, what all things you are looking for in the MRI scan?
So I'm looking for the mass, and usually Wilms tumor is unifocal and well capsulated. I will see the relation of the mass to the kidney, if there is any lymph node, and if there is any metastasis to the liver or other organ. This is my main concern.
Okay. What about the other kidney?
Yeah, definitely. I will check the other kidney to make sure that the other kidney is present and functioning.
Okay. How do you stage Wilms tumor?
So Wilms tumor, stage 1 is usually the staging is done postoperatively most of the time. So stage 1 is when the tumor is localized to the kidney and completely excised. Stage 2, when the tumor is extending outside the kidney, but it is completely excised as well, or if there is a biopsy done for the kidney. Stage 3, when the tumor is extending outside the kidney and is either not completely excised or with positive surgical margin, or there is a rupture of the tumor during or after the surgery, or if there is a local lymph node. So all these are stage 3. Stage 4 is when there is a hematogenous metastasis to the liver or lung or bone. And stage 5 is bilateral Wilms tumor.
Okay. What do you think the treatment for this patient will be?
So usually for Wilms tumor, there is no need for biopsy if the clinical suspicion is quite high. And usually treatment is by giving a new adjuvant chemotherapy, which is vinblastine and actinomycin, given for 4 weeks. And then nephrectomy will be done in week 5 or 6. And then according to the stage and the histological grade of the cancer, further treatment may be given, which can be just a follow-up if it is a low stage, or it may include further chemotherapy, or it may include even chemo and radiotherapy for the high-risk tumor.
Okay. Are you aware of any protocols of treatment?
I think there is something called umbrella for the treatment of most of pediatric renal tumor, but I'm not sure.
Okay. And what is the risk of if there is no biopsy done previously, what is the risk of having a benign lesion or having a malignant lesion other than Wilms tumor?
Usually the risk is low, because mostly at this age, the age of 3 to 4 years, it is the age of Wilms tumor. If the child is less than 6 months, then we may think about nephroblastoma. Mesoplastic nephroma, which is a benign tumor. And if he is around 2 to 3 years, less than 2, we may think about a neuroblastoma. But at this age, with the characteristic appearance of Walm's tumor, usually the risk is low.
Okay. What are the indications for nephron-sparing surgery in Wilms tumor?
Mainly it is when the tumor is bilateral. In this case, we need to preserve the kidney as much as possible, or if the tumor is not that big and localized to one pole of the kidney, then we may consider nephron-sparing surgery.
Okay, and what is nephroblastomatosis?
Nephroblastoma, I think there is some embryological tissue called nephrogenic rest, which may present outside the kidney, may present in the inguinal region, in the retroperitoneum, and other organ, and sometimes there is hypergrowth of these tissue, which is called nephroblastosis.
Okay, well done. So we are now 10 minutes now. We'll stop there. Okay, so how was it? How do you think the two scenarios went? We'll take the UTI first. How was it?
Yeah, I think the UTI was more straightforward, but the Walm's tumor is a little bit uncommon topic.
Yeah, exactly, and especially and yes. So regarding the UTI, only there's no concerns. It went well. You exactly know what are the nice recommendations on imaging, especially for that child who was 8 months old, and the definition of recurrent UTIs. And there is no concern regarding the management. Couple of things I would suggest to bring in is especially when the history is like vomiting, then definitely think about rehydrating.
Yes.
And then the NICE guidelines, the previous one was 2007. There is an update in 2019. So we had to mention that. And regarding the antibiotics, no concerns, because for lower unit tract, lower UTI, lower unit tract infection, we usually give trimethoprim or nitrofurantoin as the first choice. But then I clarified that there was no upper tract, so no concerns on that part. And that study you mentioned is Singh et al. So I have put that in the slides, so you can review that and then make sure that next time your numbers were correct. So no concerns about that part. Okay. Overall, it went well.